Yes, ma'am. Visible and audible, ma'am.
And audible. Okay. Good morning, everyone. At the outset, I thank the organizers for inviting me to speak on a rational approach to the child with chronic headache. As we all aware, headache is one of the most common ailment that haunts both the sufferer as well as the
Excuse me,
treating
ma'am.
physician.
Ma'am, can you please put the mode on slideshow mode, ma'am?
Is it okay? Hello?
Yes, ma'am. Thank you, ma'am. Yes, ma'am.
Yeah. So childhood headache drew attention for the first time in 1873 when William Henry he contributed an entire chapter on headache in a book called Disorders in Children. The frequency of headache incidence ranges from less than 10% in preschoolers or toddlers and increasing to 60 to 80% in adolescents. And the frequency is more or high in boys in the prepubertal age group, and in girls after puberty it is higher. And why there is a need to know about these headaches in children? Because there is a significant increase in the number of children presenting with the headache nowadays because of the changes in the lifestyle, increasing psychosocial pressure, competitive pressure in academics and other walks of life. On the other hand, there is also an increased parental concern to rule out underlying tumors, as well as there is an increased availability of imaging techniques. These things also contribute to this scenario. And these headache disorders are often associated with the school absenteeism, poor school performance, and decreased extracurricular activities. Coming to the pain carrying structures in the head. And these are the extracranial structures: sinuses, blood vessels, orbit, ear, nose, throat, and temporomandibular joints are the extracranial pain sensitive structures. Intracranially, arteries of circle of Willis, dural veins, venous sinuses, meninges, and dura. If there is any inflammation or if there is a stretching of these structures, children can develop headache. International Classification of Headache Disorders, 3rd edition, divides the headaches in children into primary headache, secondary, and painful cranial neuropathies. Under the rubric of primary headaches, we have migraine, tension type, and cluster headache. Under secondary headaches, headaches which are attributed to head trauma, CNS infections or systemic infections, tumors, vascular insults like hemorrhage, infarcts, disorders of head, ear, nose, throat, eye, and psychiatric disturbances. And this trigeminal neuralgia, glossopharyngeal neuralgia, ophthalmoplegic migraine, which we call it as previously, now they are clubbed under painful cranial neuropathies. Then according to the temporal pattern, we can classify the headache into acute recurrent, chronic progressive, and chronic non-progressive. Coming to the acute headaches, which happen in a day or in few days, upper respiratory tract infections, systemic illnesses, trauma, vascular insult come under this acute headaches. Coming to the acute intermittent headaches, all your episodic headaches due to primary causes like your migraine, tension type, cluster headache comes under this rubric. This chronic progressive one is your underlying any space occupying lesion or idiopathic intracranial hypertension, hydrocephalus comes under chronic progressive headache. Whereas chronic non-progressive headache, under this rubric, we have chronic variants of our primary headache, like chronic migraine, chronic tension type, and medication overuse headache. Then coming to how to distinguish between a primary and a secondary headache. Primary headaches usually, unless otherwise they are acute intermittent, they are chronic, whereas secondary headaches are subacute or acute. Primary headaches occur daily or recurrent, whereas secondary headaches are progressive. Most importantly, primary headaches, the site is usually frontal or temporal, whereas in secondary headaches it is posterior. Again, the quality is important: throbbing in or pulsatile in migraine, squeezing in tension type, whereas here it is pressure type. Again, nausea is more than vomiting in a primary headache, whereas vomiting is more common in secondary headaches. You can have visual aura in classical migraine, whereas aura is not at all present in secondary headaches, whereas diplopia is common. Again, phonophobia, photophobia is common in a primary headache, whereas it is absent in the secondary headache. Coming to the history taking, we have to seek for certain things called headache semiology, like What is the duration of the illness, duration of each episode? What about the frequency of the episodes, severity, whether it is affecting the day-to-day activities of the child, location of pain, whether it is a bifrontal or a temporal or a posterior, that is occipital. What about the quality of the pain? Is it throbbing or is it is pressing, whether there is any aura is present or not, associated symptoms like nausea, vomiting, phonophobia and photophobia. Apart from these things, we have to ask for what are the precipitating factors, what are the ameliorating factors, whether sleep or analgesics the child has to use to alleviate, and is there a family history of migraine. And again, what are the associated symptoms such as whether there is any diplopia for distant objects, presence of seizures or not, is there any focal deficit or weakness of limbs, ataxia, and then etiological history like trauma, infection, sinusitis, and whether the child is having any chronic medical underlying illness like leukemia or a sickle cell anemia, whether the child is on any chronic medication. And usually phonophobia, photophobia, the children can express if they are older children or an adolescent. Whereas in a toddler, we have to look for certain subtle signs like behavioral problems like irritability or dull. The child is having an incessant cry, doesn't want to play or watch TV, becomes dull, quiet, prefers to lie down. All denotes that a child may have an phonophobia or photophobia. During examination, focused examination should be there, and we should look for the appearance of the child, whether the child is dull, lethargic. Blood pressure is an important thing one should not forget. Look for sinus tenderness, ear, throat examination, presence of any focal deficit in the form of cranial neuropathies or your hemiparesis, ataxia. Look for papilledema in the fundus examination, macrocephaly, crackpot resonance, presence of meningeal signs indicate the child is having a meningitis or a subarachnoid hemorrhage. Look for also bruit in the carotids, which can denote or imply fistula, arteriovenous malformation. And coming to the site of headache, it can give us a clue during the clinical examination. In sinusitis, the pain is usually behind the forehead or behind the cheekbones, whereas in a migraine, it is usually unilateral in adults, whereas in children, it is bilateral. In tension type headache, it is bilateral, frontal, and it is squeezing, whereas in a cluster headache, it is in and around the eyes. Coming to certain case scenarios, a 7-year-old child presenting with headache on and off, occipital headache, moderate in severity for the past 2 months, every day for the past 10 days, associated with vomiting, double vision, and an unsteady gait. There's no history of fever or trauma. Examination reveals a bilateral abducens palsy with papilledema. When we proceeded with the MRI brain shows a large expansile mass in the pons obstructing the fourth ventricle. So this is a pontine glioma. So this is a headache, which is a secondary headache due to an underlying SOL. The same clinical symptoms, headache, bifrontal, moderate, associated with vomiting, diplopia. Examination reveals a bilateral sixth nerve palsy, papilledema, but there is no history of fever or headache. And MRI brain does not reveal any underlying tumor or hydrocephalus. But if you closely look at the MRI, you can see there is a flattening of the posterior aspect of the orbit. And in the coronal view, you can see the increased perioptic spaces, which are signs of increased intracranial tension. And we did the LP, the CSF pressure was increased more than 20 centimeters of water. So this is a secondary headache due to idiopathic intracranial hypertension. Case scenario 3, an 8-year-old boy presented with headache for the past 1.5 years, episodic, bifrontal, moderate to severe, once in 2 to 3 months, associated with nausea and vomiting. The duration, it lasts for 1 to 3 hours, and it is aggravated by day-to-day activities like walking, climbing the stairs, and it gets relieved by sleep. And the examination reveals there is no focal deficit of whatsoever, fundi are normal. So this is a primary headache, which is a migraine. So what are the criteria to diagnose migraine? 5 or more headaches lasting for 2 to 48 hours, bilateral, pulsatile in quality or throbbing in nature, moderate to severe in intensity, aggravated by routine physical activities like walking or climbing stairs, associated with nausea and vomiting, photophobia and phonophobia. There is no underlying, this is most important, there is no underlying organic disease that can be attributed to. So what are the peculiar features in children? In contrast to adults, children, the headache in adults, it is usually unilateral hemicranial. Whereas in children and adolescents, it is often bilateral. Again, the duration varies. In adults, it is minimum hours is 4 hours, whereas it can be as less as 2 hours in children. Again, when the child falls asleep during migraine and wakes up without it, the entire duration has to be taken until the time of awakening has to be taken as the duration of the headache. And again, photophobia, as discussed earlier, photophobia and phonophobia is to be interpreted by the behavioral changes in a toddler. And the last criteria is always a reminder to consider the other diagnosis. 8-year-old girl, recurrent headache for the past 1 year, bilateral, dull aching. Usually it is in the evenings or in the afternoons, at least 1 episode per month, lasts for 1 to 2 hours. It is not aggravated by the daily activity. There is no nausea or vomiting or photophobia or phonophobia. These 2 findings are important. This is not aggravated by the daily activity. Child is able to carry out his or her daily activities as usual, and it is not associated with nausea, vomiting, photophobia, or phonophobia. This is a primary headache which corresponds to a tension type headache. So what is the criteria? The duration may be as less as 30 minutes, bilateral, mild to moderate in intensity, pressing or tightening in quality, no aggravation by the routine physical activity. There is no nausea or vomiting. This is tension type headache. There are certain syndrome, episodic syndrome, which are unique to children, which can be the future harbingers of migraine. That is, among the toddlers, benign paroxysmal vertigo, that is episodes of vertigo along with nystagmus, ataxia, vomiting, associated with the pallor and the fear complex. The child will not be able to maintain an upright posture, wishes to remain absolutely still, lasts for seconds to minutes. There is no headache or ALOC. Near 40%, in 40% of the children, they can have an associated family history of migraine, and one has to rule out the differential diagnosis such as occipital epilepsy, positive foci, SOL in such children. In infants, benign paroxysmal torticollis, recurrent episodes of head tilt with irritability, ataxia, vomiting, and pallor last for days or hours to days. In between the attacks, the child is neurologically normal and asymptomatic. Usually, there will be a spontaneous remission by 2 to 3 years of age. Again, GERD, torsion dystonia, we have to rule out. Cyclical vomiting, this is recurrent episodes of intense nausea, severe vomiting at least 4 times per hour, lasting for 1 to 5 days, requiring hospitalization and IV fluids. And these episodes occur in a predictable basis once in every 2 to 4 weeks, symptom-free between attacks. This is cyclical vomiting. And if the symptoms are recurrent, then one can use preventive therapy as for migraine. Always we have to rule out the differential diagnosis such as intestinal obstruction. Again, metabolic causes such as urea cycle defects, one has to rule out. Coming to abdominal migraine, episodes of abdominal pain along with anorexia, nausea, pallor lasting for 1 to 72 hours. The pain is usually poorly localized, midline, periumbilical, dull or soaring quality. There is no associated headache. Differential diagnosis include gastrointestinal problems or renal diseases. Usually these children evolve into migraine in the adolescent age group. So what are the red flags or danger signs once when a child is comes to us with headache? If the headache is of sudden onset, worst ever headache, if the headache wakes up the child from sleep, associated with severe vomiting or worsens with cough or Valsalva maneuver, associated with any focal neurological deficits, associated with seizure or fever, exclusively unilateral, always hemicranial, or increases in severity or changes in the character of a primary headache. If the child is an immunocompromised child or has an underlying malignancy or has an underlying BP shunt and age less than 5 years, for the fact that they cannot express the other symptoms. So these are the red flags. So what are the investigations one should do whenever we come across a child with headache? Having said that about the danger signs, usually routine neuroimaging is not needed in children with chronic or recurrent headache with normal neurological findings. This is most important. But it is indicated, promptly indicated, if any one of the alarming signals or red flags are present. Again, EEG is not useful in routine evaluation, but if the child has associated symptoms which suggest a seizure, such as an episodic loss of consciousness, then one has to do EEG. And the lumbar puncture is indicated in children whenever we are suspecting underlying CNS infection, subarachnoid hemorrhage, or if the child has an underlying leukemia or a malignancy to rule out a CNS relapse, and in a child when we are suspecting idiopathic intracranial hypertension. So these are some of the imaging features. This is the first Picture is generalized neurocysticercosis with a starry sky appearance. Second one showing an colloid cyst in the third ventricle causing an obstructive hydrocephalus. Multiple cerebral abscess in a child with an underlying congenital cyanotic heart disease. Leukemic child presenting with headache showing an intracerebral bleed. A child with a headache showing an MRI and underlying AVM. Sometimes we may find incidental findings as this in this particular child who shows an arachnoid cyst in the right temporal region. So this study has addressed this issue. What about the neurological or neuroimaging findings in children presenting with headache? In a cohort of 450 children presenting with headache in which 75% underwent neuroimaging. Here, the MRI was normal in 80% and showed abnormal finding only in 20%. Among this 20% of abnormal MRI, incidental findings were seen in 10%, extracerebral findings were seen in 10%, and only 0.6% or only 1%, less than 1%, showed abnormal MRI findings related to headache, such as underlying SOL or hydrocephalus. So, which imaging to choose? If the child is diagnosed to be a primary headache, usually imaging is not appropriate or not done, not needed. In secondary headaches, it is MRI brain, including MRA and MRB, MRA to rule out underlying vascular malformation, MRB to rule out underlying cerebral venous sinus thrombosis. If we are suspecting an underlying CNS infection, then contrast has to be done to look for meningeal inflammation. If the headache is attributed to trauma, a non-contrast CT brain will be sufficient. So let us see another case scenario in which a 12-year-old female presented with a recurrent headaches bifrontal associated with nausea and vomiting. Examination did not reveal any focal neurological deficit. Mother is a known migrainer. So all points are suggestive of a primary headache in this particular child. And MRI brain was done, it was normal. So the child was put on preventive therapy, beta blocker, and then child had again recurrent headaches, calcium channel blocker, then anticonvulsants also. But the child tend to have recurrent episodes. Nearly 1.5 years into the illness, child used to have, in spite of multiple preventive therapy, child had recurrent episodes. So we had to repeat the MRI along with the MRA, which showed a typical moya picture. So whenever a child has a persistent symptoms in spite of our preventive therapy, or there is a change in the type of headache or in the character of the headache, one has to re-evaluate the child. Coming to another myth, whether there is any correlation between a headache and refractory errors. And this article, this interesting article has addressed this view. Nearly out of 158 patients with headache, nearly 75% had normal acuity of vision. Their ophthalmological evaluation was normal. Remaining 25% has had new or changed the spectacle correction, but the observation was the headaches improved in 76.4% of all patients, irrespective of the change in the refractory correction. So it seems they have concluded, it seems that the refractory errors do not appear to be the cause for headache in children. Coming to the principles of management, headache education is important. Like we have to reassure the parent as well as the child. They have to maintain a headache diary. Lifestyle modification is most important, following a SMART plan. And then acute management by using non-steroidal anti-inflammatory drugs and triptans. Preventive therapy, we have so many types of drugs like anti-epileptics, antihistaminics, antihypertensive therapy, and antidepressants. What is SMART plan? That is, regular and sufficient sleep is important. Similarly, regular and sufficient meals, we have to advise the children not to skip the breakfast. A good hydration is important. Similarly, regular aerobic exercises are indicated, stress reduction and management, and trigger avoidance. So this is the SMART, this is the SMART plan. We have to advise the patients. Coming to the triggers, contrary to our well-known views, like we used to ask the children to avoid the 5-hydroxytryptamine containing agents like chocolate, cheese and all. But this article, in which they have looked up for the prevalence of triggers in pediatric migraine, they have come out that these things, the commonly prescribed, commonly to be avoided things like cheese, colas, chocolates, they contribute only 10%, whereas the major chunk, 60 to 80%, is stress, sleep deprivation, and increased screen time. So this has to be insisted to the parents. Coming to the acute management, we have analgesics, antiemetics, and triptans. Usually, any one of the analgesics with an antiemetic is given. The strategy is give yearly. At the onset of the headache itself, one should take the abortive management, abortive therapy, and give enough. Triptans are indicated, especially sumatriptan can be used in children more than 6 years, and nasal preparation is preferred, especially whenever the child is having intense nausea and vomiting because they cannot tolerate the oral ones. And this risatriptan, almotriptan, zolmitriptan are indicated in children more than 12 years of age. And always we have to educate the parents that no more than 3 doses per week is allowed to avoid or to prevent medication overuse headache. And these are the drugs for preventive therapy. So when to give the preventive therapy? When the headaches are more than 3 episodes per month, then preventive therapy is indicated. The strategy is reduce the frequency to less than 3 per month and sustain it for 4 to 6 months and then a gradual taper. Usually, these drugs are given throughout the calendar school year, and during the holidays, annual holidays, they are tapered and stopped. And also one should remember that it typically takes at least 2 to 3 months to cause a recognizable effect. So switching over to other preventive drugs every few weeks is not advisable. Again, one should always remember we have to individualize the treatment. We can choose topiramate. This is preferred in an obese child, but has to be avoided in a child with a renal stone. Sodium valproate is indicated in a thin child, and if the child has associated seizures, this is the preferred drug. Ciprofloxacin in an younger child, syrup preparations are available, so this will be useful in an younger child. And again, if the child has associated allergy, this will be the most appropriate. In a teenager, adolescent female, especially in a tension type headache, antidips are the preferred drug. Propranolol has to be avoided in children with wheezing bronchitis and bronchial asthma. So what are the take-home messages? This headache is a haunting symptom for the patient as well as a daunting task for the physician to identify, to distinguish between a primary and a secondary, and when to investigate, what are the investigations we have to choose, and how to use the appropriate therapy. A complete history and a detailed focused examination helps the physician to distinguish between the primary and the secondary headaches. One must always search for the red flags and do prompt neuroimaging. Lifestyle modification and diary of headaches are useful in the management of primary headaches, and preventive therapy is indicated if the headaches are frequent and disabling and if they are more than 3 episodes per month. And always, whenever there are new symptoms or persistent symptoms, should prompt review of the review of the diagnosis, and appropriate changes or re-evaluation has to be done. Thank you for the patient hearing.
Thank you very much, ma'am. That was a very informative topic, and it will also be useful for a day-to-day practice. Thanks a lot, ma'am. The forum is now open to questions. If someone has questions, you can ask. Thank you, ma'am.
Thank you very much.